bricks on the screen, healthcare in between. Physics, art, and math guide us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix. Maybrick's got the fix. Complex subjects made
right
clear.
now
Every episode
in ways that we actually acquire
leads the way.
and ways that make me more efficient.
In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges.
Hey, welcome to the MedBix Webcast. This is Ramana Annamaraju. I'm the host. I am a little bit traveling nowadays from East Coast. It's extremely cold, so I got a little bit of I'm under the weather. So please excuse me about that. If already have an accent on the top of it, cold is not a good idea. But anyway, the guest is a very prominent guest today, Dr. Robert Pearl. He's a former CEO of Kaiser Permanente. And he is a truly innovator. If you're in the healthcare industry, if you don't know his name, you're living under the rocks, somewhere, because he's a very well-known. He wrote several books. I met him actually in the Commonwealth Club in San Francisco when he wrote the first or second book, Mistreated. He wrote the first book, I think, right after retirement. And then I met him there. Then I was, he was talking about brain, spine, and heart. This I may be intermingling all three, but I was so impressed by that. What that means is brain is you need to think about it. What kind of a plan you need, a future thinking. You need a brain to analyze this process, and then heart you need to have a compassion for the healthcare, and then spine you need to confront the evils, or the big Goliath, the David and Goliath kind of thing. You got to confront that. So these kind of things I immediately fell in love with his books and his writing. He writes such a clarity. I have not seen healthcare people. I follow a lot of people. He is one of the very few people, doctors, that writes healthcare so crisp and clear. Not only he writes the problems, he provides solutions. I am always amazed about the way you look at things. And let me bring him to the table. Dr. Robert Pearl is joining from Stanford. He's a Stanford faculty. Welcome, sir. Welcome to the MedBix Webcast.
Thank you, Ramana. It's great to be back with you.
Thank you, sir. Tell us a little bit about what's going on now. I wanted to ask you. You don't need a special introduction. Let me ask you a question about this Chinese. This is going on, that DeepSeek. I wanted to show you just a little bit the difference is. I wanted to ask you, what is your opinion on the DeepSeek? Let me ask you the question. They did with the $5 million, they did the entire thing. It is shaking the world of Silicon Valley. So what is your take on this?
Let me begin for viewers and listeners, again, with a tiny bit of background about myself so that I can then put this into context. Last spring, I published the book, ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine, with all profits going to Doctors Without Borders. And in that, I talked about what the future would look like. And I co-wrote that with ChatGPT because I said at the time, this industry, this world of generative AI is going to move so fast that anything that I write that went through the normal 2-year cycle of writing and publishing and distributing will be out of date. And I think that this advance brings everything we've said to this point out of date. Now let's talk a little bit about it. The first thing is we don't know that much about it. I mean, it's available, by the way. It's the #1 selling app on Amazon right now, on Apple right now. So it's not that we don't have access to it. We know certain things about it. Number one, what it does is it duplicates what I'll call it all the other large language models do. You know, if you look at Gemini, Claude, ChatGPT, there are differences, but the similarities are so much larger, so much greater. This is very similar. Of course, OpenAI today said that they accomplished that by taking some information from the website, which is prohibited by the API disclosure agreement. But having said that, it's very similar to the other ones. It's open source, which means that it's readily available and it's free. And what it does that the regular large language models don't do, unless you're willing to pay $200 a month to OpenAI today in order to obtain a version of ChatGPT. What it does do is it tells you how it came to the answer. Now, a couple of things. It probably cost a lot more than $5 or $6 million. First of all, it built on a lot of other work that cost a lot of money to accomplish. The government probably financed, or the investors financed pieces that were not counted in that number, but it doesn't matter. Let's say it's $20 million. That's compared to what otherwise would be $100 million. Now, why is that so significant? Because there are a lot of what I'll call middle-sized companies in the United States and around the world, but in the United States right now, that would love to develop their own generative AI, I'll call it bot. We may talk some more later on about some of the opportunities around creating a bot versus creating a service, but let's think about a bot right now. Well, if you have to train it all, you need a partnership. You don't have enough money as an entrepreneurial startup to fund that cost at $100 million. But $20 million, you're starting to get to the realm where it could happen. And what that means is that it's possible not only to have the kinds of applications in generative AI right now that can answer any question, but are expensive to create, but you can shrink it down and narrow it down and have it disease-specific, problem-specific. And that is what's going to open up this field. You know, the idea that somehow this will bring the price down of a particular application, but it'll escalate the number of applications. And so generative AI now is about to explode, which I say is something we could never even have predicted a month ago.
Dr. Roberts, I'm going to be a little bit critical of this process a little bit, if you don't mind. They're asking for $500 billion, the government, the OpenAI, and then Larry Ellison and all those people, that all the people are asking $500 billion. Then whereas of $5 million that a Chinese company produced this, so the open source to the RTAGI. So what is happening to where the money, this $495 billion and $995 million, who is getting that money, sir? Let me ask you that question.
Well, if what you're asking is what's going to happen to that money, that's easy to see, because NVIDIA that manufactures the very expensive chips, the GPUs that allow I'll say the current large language models to work, lost $600 million of value in one day. So that's where a lot of the value has gone away. Now, it may come back. But the design of this, and it's interesting that it was built out of a research mentality, and it was built in a way that it could use far less expensive chips. Because remember, the US government prohibited the sale of these high-end GPUs to China, so they had no choice. And they brought in researchers who said, what we're going to do is we're going to change how this system works, how it learns, and redesign the entire process from what Google, Gemini, and Claude from Anthropic, and ChatGPT from OpenAI were doing. But as I say, it's likely that it built on what came before rather than being a completely new innovation.
Yeah, I think we need to re-examine all this, why the public has that investment. We have to make it. We have to re-examine that process here. Do you agree with that one? If you don't mind asking you.
I think it's going to shift that process. I think there's going to be need for some of the very comprehensive, high-end, very major data analytic, data entry tools that will be very expensive to build. But I think for a lot of the other applications, it won't need that. And it's the equivalent of being able to say, I have a machine that's very expensive that I can produce parts on, or I can buy machines that are a tenth the price. Let's say a portable ultrasound versus a large multi-million-dollar device. And I can do not everything, but I can do certain things. I can certainly evaluate the heart using my portable device, reasonably equivalent to the very expensive one. And in that way, again, the tool gets in the hands of more people. Used to be you need a big institution to have this device sitting in play, and now you can put it in the hands of individual clinicians. That changes the application. I've said all along on the show when I was with you before, what we had at that time, I called 2% of what's going to happen. Now we're maybe at 5%. This was the iPhone when it first came out that was seen as an alternative to the telephone. No one saw it as a device essential to drive your car, to order your products, to have things delivered to your house. All the tools to take the pictures, create the videos, all the things that we do with it now, we're probably at the 5% mark. And that's why I'm so critical of when clinicians say, oh, this is not very good today. It doesn't matter what it's like today. It's doubling in power every year. And with this advance, by the way, it's going faster than that. That's 32 times more powerful. It's going to be it's the equivalent of your car going as fast as an airplane. You wouldn't be asking yourself, where am I going to drive tomorrow? You can be asking yourself, where do I fly in my car tomorrow? And that's going to open up a whole new panoply of opportunities.
I will get back to you on the ChatGPT and all this open AGI a little bit later on. But I wanted to ask you of any tragic story. And you wrote a beautiful article. I read it about United Healthcare CEO Brian Thompson. My son's fiance, she works for him, and she said that a lot of people told her that he is one of the best guys, and he talks very open. He's accessible, a very nice guy in person. So, but the tragedy is that, is beyond words, but also the frustration it shows. The other angle he showed is a frustration among the American public. So tell us how that the balance of that kind of a craziness and the frustration, how the American public is suffering in this process.
Let me start by reiterating what you just said. This is a tragedy beyond tragedies. There is never a justification for one human being killing another human being. I don't care what it is, unless it's clearly in direct self-defense or something with some abuse directly happening to someone you love. These are the kinds of things that may be justified depending upon what happens in the legal proceeding. So in no way am I about to say is a justification for what the shooter did. But in the article that you're alluding to, I talked about the fact that so many people put up smiling emojis after United Healthcare put up the announcement on its homepage. And the interpretation, I think, was, and I'll call it intellectual. We talked about the problems of the system, the problems of prior authorization, and the problems of getting care, and they are very valid. But I don't think people put up those emojis over that. You use the word frustration. Frustration is what I feel when I stand in a grocery store line. It's what I feel when I need to get my driver's license renewed, and I call the DMV and I get on hold for 20 minutes or 30 minutes. That's frustration. This to me was anguish and agony. I allude to the fact it's the equivalent of being behind a tall metal fence, and on the other side, someone you love is being tortured. It's this intense pain of your helplessness, of your powerlessness. It's beyond that which is intellectual. It is just primal. And I think that's what so many people are feeling. I mean, just imagine if you had a child who had a medical condition for which there was a treatment, but without that, he would die, and all you're getting is recorded announcements and delays in time, and we're going to look at it and send us a new letter. Yes, those things would be frustrating, but that's not what you're feeling. You're feeling the inability as a parent to save your child's life. And I think that that's what we need to learn. And what I conclude the article with is this notion that once you can feel that pain, once you just imagine what it would be like if that was my child dying and I was there and couldn't do anything about it, then you only got two choices. You either say, I'm going to act. I'm going to make a change. I'm going to make this something that never happens again, or you have to admit, I don't care. And I think that's where we are as a nation, and I'm optimistic. I'm hopeful that out of this, if there's a silver lining anywhere in the death of a human being, it's that lots of other lives will get saved in the future because there are better ways to do it than the way the current American health system provides medical care.
Let us talk about better ways. You just mentioned, you know, that Andrew Whitty, there's a new CEO of the United Healthcare, said that no one would design this kind of a healthcare system. You know, it is placed under us. We became no one with the right mind, I would add, right, designed this system. And then we were posted into the system, and we are all doing the patchwork all these years. So what, Dr. Perl, you're very understanding the healthcare system in the global level. Tell us what kind of healthcare system you want to design.
I always start with what's the fundamental problem that exists. American healthcare is overly expensive. American healthcare is increasingly difficult to access. And we don't do a very good job when it comes to things like longevity. Now, there's probably 50 different reasons that contribute to that. And they are important. Again, things like the fact that the government can't negotiate for drugs on our behalf, or the fact that we have a electronic health record doesn't communicate with other places. We could go down and list those 50 things. But when I look at what's the biggest factor, it's the epidemic of chronic disease. Now, why do I say that? Because if you go back 30 years, you don't see the same level of chronic disease, and costs are lower. And as you watch the escalation, 60% of Americans have a chronic disease, counts for 70% of cost. But what's exciting to me about that is the reality, according to the CDC, that if we could control chronic disease as well as people do today, not perfect, but just as well everywhere as the best in the country today, 30 to 50% of heart attacks, strokes, cancers, and heart attacks, strokes, cancers, and kidney failure would disappear. Now, I want you to think about that. What would happen to the quality if 30% of heart attacks, strokes, kidney failures, and cancers, to say nothing about lower limb amputation, was all of a sudden didn't happen? Quality would soar, life expectancy would go up, and what would happen to the cost? It would crash down. So now you got to ask, why do we have so much chronic disease? Now, again, it's multifactorial, and there are things that we have to do in the area of obesity, which has doubled from 20% of Americans to over 40% over the past 30 years. There are things that we need to do in terms of restructuring the way it's all organized. But the biggest piece to me is changing the way that we pay. Charlie Munger said, tell me your incentives and I'll tell you the outcomes you're going to get. Incentives in fee-for-service is only higher volume. As soon as you move to a prepaid, a pay-for-value, capitation, all the words the same. And I don't mean at the insurance level. I mean at the clinician and hospital level. Now, all of a sudden, you align those incentives. How do you do well financially in a capitated system? You prevent chronic disease in the first place. You better manage chronic disease. Hypertension, 40% of strokes are caused by hypertension. We control it 60% of the time. The best places are at 90. Diabetes, we control blood glucose less than half of the time. This is the leading cause of heart problems and kidney problems and peripheral amputation. These are opportunities that we have, and we don't take advantage of them. And what's so exciting to me right now is we now can combine technology, the ability to manage, to monitor using wearable devices, analyze through a generative AI application, patients at home continually, not every 3 to 4 months in our office. And I'm confident we could then solve the problem. You know, when I was the CEO in Kaiser Permanente, we were over 90% in hypertension, but we had 250 RNs doing it. That's cost prohibitive for almost anyone else. Now you have a generative AI tool, and all of a sudden you need a tenth that number of RNs. And now it becomes very, very cost effective. And as we mentioned earlier, it's possible with DeepSeek. You only need 5 because the tool will become so ubiquitous and easy to use. We'll see how it all goes, but we're opening up that piece. And if we could do all of that, I think we can address that. Why do insurance companies have prior authorization? Because they're trying to rein in cost. They don't control clinical operations at all. This is the only thing they can do. As soon as you make healthcare affordable, you don't need any prior authorizations. As soon as you capitate at the clinician level, you don't have anyone to ask for approval.
Dr. Pearl, you said the systemic problems that they have. They're asking the physicians to solve it, the societal problems. That is one thing they must raise voices. The physicians has to raise a voice. These are the societal problems. It is a larger sense. If, for example, I used to place doctors in Alabama, in a small rural towns. They don't have a nutritionist for the 10, 20 years. So the systemic problems, how do you address that? I think sometimes the providers are taking the wrong end of the blame for that. Some extent, what is your take on that, Dr. Pearl?
I don't blame the doctors for it. I think that there's a lot of different reasons. I talk a lot about obesity. It's the processed foods, high caloric, high in fat. We need to be able to have congressional action on that. I think GLP-1 drugs need to have lower price. We spend cost $1,000 a month in the U.S., less than $200 elsewhere. There's no justification for it. Yeah, we have a lot of other people that need to move along, but I tend to focus on what we can do. Yeah. And as clinicians, those of us who are managing patients with a chronic disease, we have a desire to be able to control it better. Now, you could ask, do patients not want to get better if they have diabetes? Do they want to be out of control? I don't think so. We just haven't had the tool until now. We have that tool now. I think it should be the medical societies that are leading the parade, looking at how can we use this on behalf of patients. Not every doctor figuring it out independently. I'm talking about creating YouTube videos. I'm talking about creating written handouts, links, other ways to help patients to do it. And I'm absolutely convinced that we can achieve levels of control that are unimaginable today, by the way, with less work for the doctor and with lower levels of burnout, not more, with an improved doctor-patient relationship, not an erosion of it.
There is a screaming match going on in Washington, D.C. now at this time. So, that Robert F. Kennedy is getting confirmation hearings. One of the things, there is another lady joining with us. She's a good friend of mine, Swapna Patel, and we are friends. In India, I had 3 vaccines, Dr. Pearl, TB, polio, and saved us, all of us. 3 vaccines. That's fine. There's a big ones that why we have, when I came to this country, I had my 2 children. It's like 15, 20 vaccines. That's too much, too many. I don't even know the implications of all those things. But how much science behind that? We are all safe. We Indians with the 3 vaccines, we are doing fine. What do you think? How do you justify this array of vaccines? I'm critical a little bit about that. Excuse me, but I want to know the truth. That's what it is per year.
Well, one of the things we've never talked about is greater detail about the cost. I don't call it cost-benefit relationship of the various vaccines. As you well know, Samoa had 80 people who died, 80 kids mainly, from lack of a measles vaccine. My great grandmother, she would have been, died at age 5, or I guess my great aunt died at age 5 from measles. These are lethal diseases. Polio. I mean, this was something that people died from, became paralyzed. Yeah, these are ones in which the vaccine is tremendously excellent. COVID vaccine, if you're immunocompromised or you're old with multiple chronic diseases, is also excellent. COVID vaccine for young kids, I suspect the data would say the difference is very, very small. So I don't, the number doesn't bother me. HPV, on the other hand, I think is a good vaccine because I've taken care of way too many people with cancer of the head and neck when they didn't have that. I know too many women who've had cervical cancer and some who've died because they didn't get the HPV vaccine. So each vaccine to me is different. Tetanus is a terrible problem when you developed, in quotes, lockjaw. I mean, so each vaccine is different. Smallpox, we would never get rid of a smallpox vaccine because that was a lethal disease that's now completely gone. So that's what I would say. We have to stop this yes, no. We need facts, transparency, and we need to understand not just in general how does the vaccine do, but how does it do in each age group. And that is what tells us to do. For a parent not to vaccinate their child against measles or polio or smallpox, I can't support that in any way. The science doesn't agree with it. If they decide not to give a COVID booster, yeah, I understand it completely. What I would do doesn't really matter, but I am not going to impose something when it's just 55-45. When it's 95-5, no, you can't convince me that all the potential risks are worse, but inevitably will happen in a population from these very communicable diseases.
Thank you for that balanced picture. Very good. So yeah, they saved in India. Me and Swapna realized that if we say this, millions of people saved from polios. There is a cholera and all those excellent they did. There is a balance there. And sometimes when they go excessive, there's a problem, and then people are questioning and they need to support that. Why they have to do that? They don't. Let us go back to your favorite subject, ChatGPT and OpenAI and all those things. Now everybody is talking about super agents. What these agents, what is the design of these agents do? What is a function of these? Actually, explain to us before we go. Some of the doctors may not know what is AGI means, artificial generative intelligence. It is. So could you please explain to a little bit about that, and then go back to what do these agents do?
Agents, okay. Well, this notion of general intelligence, the experts can't agree. So the fact that other people don't, it's the idea that at some point, these very sophisticated generative AI tools will be smarter than the smartest human. Now, why is that? How's that possible? Well, if you think about it, imagine a medical student who had read every textbook and memorized and knew every fact from every textbook, every journal article. Immediately, they knew the answers to all of that. You would think this guy is amazing. You would love to have this individual around you to help you with expertise. Well, today, that's what generative AI can do. It's already been pre-trained with all that information, and it can provide it. So that day is coming, but to me, it's somewhat of a very artificial line. It has to do with the great fear that sort of like the movies, that the application, the bot, will take over and subjugate humanity over time. I'm not very worried about that. I think I'm very focused on the problems that it's going to solve. So I don't worry about that level, but that's talked about a lot. But what's agency? So agency is the notion that you can actually give the application a task to complete, and it can do it without human oversight. So if you think about that, right now there are tools that will say, I want you to organize my emails in a different way than it was. And it can go into your computer and organize those emails differently. I would like it to create a calendar for my family with all the dates and all the things that should happen. I use it actually every Sunday when I want to create the meal plan with my wife for the week. And we use ChatGPT. We tell it what we want. We say, we had a couple of heavy meals this weekend. Go a little light on the calories, or we say, we're a little short on vegetables. See what you can do. Or we say, we're gonna splurge a little bit. This is a little time for celebration. Whatever we tell it, and it gives us a list, of shopping list, a recipe list of everything we want. That is what agency starts to look like. It's not as though we bring in a chef or we bring in a nutritionist to oversee that process. But what's important to me about agency in healthcare is that we can start to turn over aspects of our own health to a generative AI tool. Now that is terrifying for so many people. So many people say, no, you can't do that. No, you can't do that today. But that day is rapidly coming when it's going to be able to manage your chronic disease, be able to figure out what preventive services you need, provide the assistance around it. It's going to be able to monitor how your blood pressure is doing, how your blood glucose is doing, how your breathing is doing, whether you have ankle swelling, weight gain, all the things that we look at. It will manage that continually and tell you what you need. You'll be able to put symptoms in place. It will give you that diagnosis as though you were consulting with a physician. It has to link in, though, with the healthcare system because it doesn't have prescribing rights. But those are the kinds of things that agency means. And these are tasks that we do in our own brain. On pieces of paper, we create lists, or we use our iPhone and we put it into our notes, that now we can just turn over to the application and not worry about it. It will be there whenever we need it for whatever action we want to take.
These are the small task-oriented agents or task-oriented solves. Say if I have an individual practitioner in cardiologist practicing in rural Georgia or rural Alabama, how does these AGI, artificial generative intelligence, or open any large language models, how do they help them? Can you give us one example of that, at least for me, please?
Help who's them?
The individual private practitioner who is doing a private practice in rural Georgia, for example. How does it help?
So a practitioner in rural Georgia has way too many patients than he or she should have. Why is that? Because that's an area that has a shortage of clinicians. So how do you manage, let's just say a highly skilled doctor can take care of 2,000 patients on a panel. Obviously, it depends upon how old they are, how sick they are. They just make up a number. But you're sitting in rural Georgia and you got 4,000.
Yeah.
What are you going to do? Well, one thing you could do is you could just skimp. Instead of seeing him every 3 to 4 months, you see him every 6 to 8 months. Yeah, that's often what happens. And the outcomes are not particularly good. Not because you're not a great doctor, because you just don't have the time to take care of that many people. Right. Now you can assign many of those tasks to this application. That's one of the things that I'm very encouraged by. Everyone's worried, will generative AI replace me if I'm a doctor or a nurse? No. What it will do is it'll fill in the times when you're not there. Again, we see someone in our office, they have a chronic disease, and we say, come back in 3 to 4 months. What happens in between? We have no idea. Now we have the opportunity to be able to segment. I don't want to know about 100 patients. I want to know about the 10 who have the biggest problems, the 10 who are at greatest risk. And by the way, 50 down here, I can see them once a year because they're doing well. And we can't do that. So now the person in Georgia, the doctor you're talking about, or by the way, the home nurse service overseeing patients, they can take care of more individuals safer, not by skimping, not by cutting corners, safer. Because what they're going to know is who are the ones at greatest risk. You come into round in the hospital, or it's the evening in the hospital, you want to see the 10 patients who are most likely to deteriorate tonight and be in the ICU. The ones who are going to be fine in the morning, you may see them, but it's not going to have any impact. That's what this is able to accomplish. And I think particularly it could be rural Georgia, it could be inner New York City. It doesn't matter. Where there's a shortage of clinicians and therefore physicians are overloaded, it will fill in a way that will allow, hopefully, the outcomes to not only be as good as people have today, but better.
And there's a lot of devices coming in. For example, PPG devices. There you can. I want to show you one device just to put in the plug in a small table lamp. It can It can read all the heart rate, pulse rate. All of them are doing that through light absorption, So those are really can make a big difference in the device side. You tell us a little bit about that, Doctor?
Well, absolutely. This is the point. So, I use the example of hypertension. There are wearable devices. I teach at Stanford Medical School and Business School, and right across the street from the business school is the engineering school. And there are devices there that are the size of Band-Aids that do exactly what you're talking about. They read blood pressure, pulse, blood oxygen. It doesn't matter.
Yeah.
And just say, you prescribe a medication for hypertension, and the device reads 3 times a day. So at the end of the month, you have 100 readings. 92 are normal, 8 are abnormal. How are you doing? Oh, I'm doing great. 92 are normal. Oh, I'm doing terribly. 8 are abnormal. You don't know. It's a simple calculation. Look at the first and second derivatives, figure out if they're getting better or not getting better or getting worse. And now you at 1 month can figure it all out. I don't know a single clinician who is using these kind of devices because none of them want 100 blood pressure readings on all the patients who are hypertensive in their office every month. That they can't manage it. Suddenly you can. So all that data, by the way, if you look at, inpatients at the bedside have all those monitors, right? It generates a terabyte of data every year. That's 14 zeros.
That is it.
97% of that we throw away. Never look at. Imagine what we could learn if we could go back and say all the patients who got admitted to the ICU this year from the ward, can we find, and match them against another, patients equal number who didn't? Can we find the differences? Can we figure it all out? Could we have seen it? I mean, again, you do this. What are we talking about? We're talking about the alarm rings when I die, when I have a cardiac arrest. No, I want to know at the first sign I'm going in the wrong direction, because now I have 2 hours to intervene and prevent it from happening. And by the way, if you have that cardiac arrest and go to the ICU, your chances of dying assuming you survive the ICU and go home, are still 4 times higher over the next 3 months. No, these are opportunities, and we pay no attention. You're a therapist, a mental health therapist. You see a client, you're worried, they're depressed, they may be suicidal. I'll see you in 2 weeks. What happens those 2 weeks? You have no idea. How do we provide a tool to evaluate them on a continual basis? That is what this technology, it's going to augment what we do. We're going to look back at this time period and think of it as being Middle Ages, not because our doctors weren't very smart and dedicated, but because they didn't have the tools. Still like medieval serfs, working with their hands in a very fragmented area without technology that came into the Industrial Revolution.
I saw that the lamp, for example, in JP Morgan Healthcare Week, it is just amazing that it reads from a distance, it reads the heart rate and pulse rate, and then SpO2, all of them. It's a very amazing. That's what is coming to. It's really, really but there is another aspect to it is I want to talk with you about the bias. These some of the pulse oximeter, for example, as some, a lot of doctors, some black physicians are complaining about it seriously about that. There is a bias involved in that in the AI. There's not only in the AI is one bias, and then devices itself is a problem. Tell us a little bit about that. How do we solve this problem?
Yeah, this is such an important area, and it's why I often talk about the fact that generative AI is completely different than the narrow AI. The narrow AI is what we've had for the past 20 years, 25 years. There's 1,000 narrow AI applications approved by the FDA. Almost none are being used outside of research opportunities and areas. The bias in the narrow AI, that's where it was first found. They took patients trying to find individuals who should get more resources because they're likely to get sick this year. This was done by United Healthcare. And they selected about 15% of the patients were Black patients. And when independent researchers went in there and studied it, it should have been 45%. It wasn't the bias. It made the assumption that if a patient gets less health care, meaning less cost for care because they had all the claims data, that they were healthier. The truth is that Black patients in the United States with exactly the same problem as white patients get $1,800 a year less medical care. The bias wasn't the bias of the technology. It was just duplicating human biology. If the technology didn't exist, humans would have still done the same thing. And that's what we've got to understand. Generative AI is different. Generative AI is not using those data sets. It's using what's in the literature. Now, what you're pointing out is another piece, which is that, again, I go back to human-derived decisions. The technology that's being built doesn't do a good job in certain circumstances. When we measure pulse or blood pressure and you have darker skin, it's tougher to penetrate with the light beam that does it. It makes total sense. So we need to figure out a different way to do it. Our clinical trials need to be structured differently. But this is not the technology. What the technology is able to do is to use those devices. And if there's a problem with monitoring, that's one thing. We got to solve that. But once the data comes out, the big problem is analysis. And unfortunately, and you've seen the articles in the New England Journal of Medicine, even with that data, if you change the name of the patient from a traditionally white name to a black patient's name, you're going to get different recommendations about cardiac intervention. So the bias is in our humans. It's not in the technology. The technology sometimes duplicates it. It doesn't make it worse. And generative AI should be better than everything, all the other AI applications that have been developed in the past.
There is another worry, Doctor, that is most of the AGIs that you mentioned is not overhyped a little bit. The dangers about the AGI, the dangers about them is overhyped. But there is a fact. It is that AGI not just work on the trained data. It is started thinking a symbolic way. It is started thinking in its own terms. It's showing that some emergent property. It is showing it is an intelligence of its own. That is a concern, because if some evil guy in some other continent sitting down in the bed in thinking about plotting the bad deal, he wanted to change the protein to the bad virus, a deadly virus, that could be that makes a little bit concern. Is not totally out of the way, but is overexpressed, of course. But to tell us a little bit about that, what do you think of it?
You're absolutely right. I mean, people who want to do bad things can do bad things. People who want to use a search engine and download a 3D printable gun are doing that already.
Yeah.
People who want to know how to build a nuclear weapon can do that by clicking on various links, going to the library and finding articles. Yeah, there's a lot of bad things, and I don't think we can regulate that. One thing I'll guarantee you is that all these bad guys aren't going to be buying their generative AI tool from OpenAI. They're going to find a different way to do it. By the way, that does raise a question, because a lot of people are very concerned with the open source AI, that it's going to make some of these very bad things happen more easily. But you're absolutely right. Every time you have a new technology, every time you have a powerful new invention, it can be used for good purpose or bad purpose. Cars can take us places. Cars can kill people. These are the kinds of ways that they go. Their vaccines are going to have some negative. They're going to have a lot of positive. If the positive is 100 to 1 or 1,000 to 1, that's just part of the advances that happen. Every technology has that. This won't be different. But what you're raising is really the question of how do we want to approach the world? There's so many bad things in it right now. Whether it's weapons, whether it's nuclear possibilities, whether it's some kind of evil person wanting to put a virus into the water system. I mean, there are TV shows all over the place about all these terrible things can happen. And this is, to me, just one more. It's no different from the fact it's not the technology, it's the people. And what are we going to do about the people, not how are we going to regulate the technology? Because they're going to get the technology one way or the other. The question is, how do we use the technology to prevent them from doing the heinous crimes they're likely to commit?
Talking about the world, Dr. Perel, we pulled out from the World Health Organization, the US government pulled out for some reason, some understandable reasons, because they became politicized. And we still don't know where this COVID virus came out, the coronavirus came out from a lab or leaked lab. I'm sorry. The gain of function research, for example, I wanted to ask you, is that to create a manufactured virus, so you mutate all the viruses in different forms and see what we can future we think about designing the vaccines, right? But It doesn't make any sense to me giving that kind of funding to the other countries, foreign countries, to do that. It is kind of a national risk to you. It is kind of a without a control. When there, I think one of the Trump administration concern is that is the unlimited the funding these kind of things in other side, and then World Health Organization political leanings of the World Health Organization. What do you think of that?
Well, the first thing I think is that, to the best of my knowledge, viruses don't need passports to go from country to country, and bacteria don't respect country lines. So we're in a global world. You know, the mpox sitting in Africa poses great threats to us here. The bird flu that we're seeing right now, it's in the herds in the United States. I can't imagine it's not in herds elsewhere. Depending upon the policies that we have, we are going to be at risk. And so to me, I tend to view everything, as we've said throughout this discussion today, from relative risk. Is the risk greater or less? And I think the risk of not engaging with the leaders of other countries is worse. Now, you know, we're 8 or 9 days now into the new president's term. He's has a history of being a negotiator. How much of this is around negotiation? How much of this is around payment? How much does it get resolved? I don't know. I don't like all the chaos, but I have no control over it. In the end, I think it's essential when it comes to infectious diseases that we, for the climate or water or a lot of other areas that pose risk to our health, it is a global problem. And the idea that somehow, you know, if we were New Zealand, maybe we could just put up walls around our island. The U.S. can't do that. So from that standpoint, I think we have to participate in it. The details about what do we approve or not approve, I think we need people who are more expert than I am around things like that. I don't know whether the benefit of doing the kind of laboratory experiments you're describing and having vaccines available in advance is worth it versus the risk. Everything I view from risk-benefit analysis. If the thing is 50-50, I say don't do it. Why take a chance? 55-45, it's probably still not worth doing. 90-10, yeah. I want to do 90-10 all the time. I don't want to do 50-50s. I certainly don't want to do it if it flips around to the other side. We just have this black and white notion that's there. Medicine is all about probability. I mean, that's the reality of the craft that we learned at the time that we studied. Everything we do, we make a diagnosis. It's not 100% definite. It's probabilistic. Even cancer, called cancer, but a lot of cancers never develop and metastasize and kill us. Maybe the treatment's worse than the cancer. There are a lot of things we've got to be looking at. But to me, I take it all back. What's the risk-benefit analysis? And when that risk-benefit analysis is 90-10, I want to do it every time. And when it's 51-49, I never want to do it.
Just to talk about risk-benefit analysis, very, very good point you made. So you are a great cheerleader for all the LLMs and all the ChatGPT. So let me ask you a question. Why can't we get rid of why the insurance company function is risk-benefit analysis, right? The risk analysis, what they do. Why can't we get it of completely altogether insurance companies through these LLM models?
Why can't we get them to use them, you mean?
No, we get rid of the insurance companies. We don't need an insurance company. Why do we need it? The LLMs can do the much more better risk analysis than these people that sitting down in the cubicles.
Yeah. First, before we even go there, I want to make a point to, again, your viewers and listeners. I was a skeptic and a critic of AI before generative AI. I could see all the problems that were there. I mean, I predicted that Watson would fail, not because it wasn't great technology. Tremendous technology, but it was using the electronic health record that I knew was flawed.
Yes.
Copying and pasting and subjectivity. And I know that a LLM magnifies differences. It finds small differences and uses that to create clearer understandings. And that is why I said this will never work. And it didn't work. It hasn't worked. So I think that people shouldn't think that I'm always just a cheerleader for these things. Generative AI to me is different, just like I was for the iPhone. I was a big proponent of the iPhone because I could see how it would change our lives for the better. I agree with you. The truth is, we really don't need insurance companies. We need someone to help us I'll say, collect enough individuals to be able to modulate the risk. That's what insurance should do. Your house is probably not going to burn down. My house is probably not going to burn down. All the viewers and listeners' house is probably going to burn down. Maybe one of our houses will. The problem is that none of us can afford to rebuild it, our own house. So we need to have insurance in case that happens. I hope you don't get a, problematic cancer, and I don't get it, and listeners and viewers don't get it, but one of us will, or 10 of us will, and the cost is going to be $250,000, and none of us can afford that. So that's where insurance needs to work. So do you pool that at the government level? Do you pool that at the private level? That's a different question. But to me, insurance is misused today. And by that, I mean, we have a view that it somehow is managing healthcare, and it doesn't do that. It doesn't do that. It manages and processes claims and things like that. And as I said earlier, the only way it therefore can limit the cost is to deny care. I'm very committed to lowering the cost of care by raising the health. Don't lower the cost of care by skipping on treating heart attacks. Avoid them in the first place. Yes. Align what patients want. I don't know any patient who wants cancer or a heart attack or a stroke. And how do we help them to avoid that? And I don't see that as an insurance function. I see that as a clinician function. And so that's why I go back to this idea of moving the payments out of fee-for-service into capitation at the level of doctors and nurses and other people in an outpatient and inpatient environment.
Let us talk about the same concept of the hospitals. What on the extent hospitals are episodic care they meant for, but they started getting involved with the primary care, the chronic care management. That's what you're saying. If you can prevent the chronic care, they are totally not equipped to prevent the chronic care diseases. So why can't we federally subsidize the hospitals and take away the chronic care management from them? That can reduce the tremendously cost of healthcare. I wanted to ask you your opinion on that one.
Yeah, there's so many problems. You said I've written 3 books. My first was about the system of care. In Northern California, Stanford's sitting in Palo Alto. For the people who are listening or watching in another country, there's San Jose and San Francisco, 2 large cities. They're separated by 50 miles. And over 50 miles, there's 14 hospitals doing heart surgery, many of which do fewer than 250 cases a year. That's less than 1 a day. How do you run a high quality, cost-effective cardiac service when you're doing fewer than 1 case a day? You got to always have your pump team. You always have to have your nurses. Everyone's got to be available. And how much experience do they get? This is a, outdated way of thinking about it, but this is where the fee-for-service system comes into place. So I think it's not a question of taking over the hospitals that we have. We need to have hospitals distributed in a way that makes sense. We need to have centers of excellence that do high volumes in particular procedures. If I want to have a surgery done, I want to know how many you did last year. And if it's a relatively common operation, it better not be 2 or 3 because you're not going to be very good at it. If it's a very rare operation, it may only be 15 or 20, but that's a lot because no one else did more than that. That's where I think all these systems are broken. Why? Because they're still left over from the last century. Think about that. In the last century, what diseases did people get? Acute disease. They broke a bone, they had appendicitis, they got pneumonia. They either need to have a cast done, they need to have a antibiotic prescribed or a procedure performed. That was it. Maybe intense for a short while, and then they got better. By the way, life expectancy back then was around 65 years of age. Now we're in a whole new world with chronic disease. As soon as you walk into my office and you have diabetes, I need to see you 120 times over the rest of your life. Totally different. And we're still using the things. It makes total sense. Fee-for-service when you have appendicitis. It doesn't make sense, fee-for-service, when you have diabetes and kidney failure and heart disease and peripheral vascular problems. It doesn't make sense to manage that in episodic care. It doesn't make sense to manage that by fragmenting clinicians. You need a system to coordinate it all. And what you're saying is how best to organize that. And unfortunately, I'm not sure we have the answer to that yet. I know how I might do it, but I don't think the government can do it. I would hope the insurers could be a force to make it happen. I know that generative AI and other technology, telemedicine, by the way, and generative AI fit together, because if the generative AI tool finds a problem, telemedicine is how you address it, not by an appointment in the office 3 days later. So we don't quite know how to accomplish it, but I think it is doable. And if we accomplished it, I think we'd have hundreds of thousands fewer deaths a year. I think medical care would be affordable. I think we could make burnout be a relatively rare phenomenon. And I think we could have a healthcare system designed for the 21st, not the 20th century.
Dr. Parola, the last question I'm going to ask you about the longevity. We had a traditional thinking, once you retire, you're done, you don't need you. Now, people like you, such a valuable for complex problems we have. Your wisdom, your knowledge is very valuable. So I think longevity helps in the transform from the solutions it will find. Longevity side, people living longer, how do we make it quality life better for them and people like you to give a much more productivity, make us productive more? Tell us a little bit about it.
Well, I'm on my third career right now. I started fixing kids with cleft lip and cleft palate, then I became the CEO, and now I'm trying to improve the health of the entire nation. I'm sure I'll have a fourth or a fifth career. I'll probably die still working. So that's just my, intrinsic genetics or whatever that's going to be. But you're raising a really important part, which is that it's not just longevity, it's quality of life. And there was some very interesting work about lifestyle that pointed to, I think, something like 7 things that if you did that, not only extended your life by 7 years, but 6 of them were good years, as measured by absence of disease and lack of need for hospitalization and other things. And these are very, very basic. It has to do with what we eat, it has to do with our exercise, it's avoiding cigarettes, it's avoiding isolation. So there's a whole, people can look up the 7 pieces. They can go to my the podcast that I do with Jonathan that is called Unfiltered. And on that podcast, Jonathan talks about exactly what the 7 things are and what to do about them. And if we did all of them, we would be in a situation we would have a good life. I think we know some of the things that are problematic. We know that too much alcohol. We know that cigarettes. We know that excess weight and obesity. We know that isolation. The Surgeon General has talked about quite a number of these. And I think that if we're able to address those, we could move things along. And again, we need to be able to provide healthcare. We need to be able to focus on some of the social determinants of health. We need to be able to improve our diet, the food that we eat. We need to be able to have groups and communities. And unfortunately, I see all these pieces as not as good now as they should be. And I'm hopeful that listeners and viewers are going to be ones to lead the process and make the changes happen, make it in your local communities, look in your local facilities, wherever you might be around the globe. There's much that we can do. We know what to do. The big gap is between the knowing doing gap. All too often we know what to do and we fail to accomplish it.
Yes, Swapna, if you are there, just come on, say one word. I wish that you could come on camera. But do you have anything to say, Swapna? I think she's.
Hi, Dr. Pearl. First of all, thank you for all of your thank you for all of your insight. I've worked alongside Ramona and just in the sales field in healthcare and devices, software, as well as in home health and health insurance. I've kind of been in this realm for about 15 years. I was curious to see if you had any thoughts as far as the longevity of independent practices. I personally am a supporter of physicians staying independent as much as they can. And so I wanted to see what your thoughts are with all of the developments, in AI and technology, and just the changes now with the new president, where you see that going.
I talked to a lot of people who left, I'll call it private practice, sold their practice to a hospital or private equity group. And without doubt, the majority of them regret the decision. They said they've lost the autonomy. They said all the big financial promises have been failed to deliver. So I think that there's no question that people are leaving it not because the destination is a great place to go, they just can't make it happen. I'd offer a middle position between the two extremes that you pointed out, which is I think that people need to work independently, but they also need to be connected with other clinicians. You don't have to be in a group where you sign up and pay an initiation fee. You can just do it with the people in your community. And I think a generative AI tool will allow us to coordinate that care. There's no individual clinician who can accept capitation. You need to have a group of clinicians, preferably multi-specialty, by the way, who are now going to work together in a way to provide the care. I think the big problem isn't, I'll call it the solo practitioner versus the group. It's the fact that you've now subjugated yourself. You sell your practice, and as part of that, you agree that you're going to be under an administration, not one of clinicians, but one led by administrators. And I think it's that process that is problematic, that leads to the challenges that are there, because they have a different set of priorities. But I think across the community, there's more things about the clinicians that are alike than different. And then I, talk about the fact that if you're a patient, you may need a cardiologist, you may need a hematologist, you may need an orthopedic surgeon. And how do all those people work together as one? How do they connect? Right now, the electronic health records are not connected with each other. Generative AI could change all of that. The care delivery is not connected, and everything has no economy of scale. If we have 10 of us, we can hire someone to help all 10 of us using a generative AI tool. You mentioned earlier that you've been involved with home monitoring. Think about that. You have a nurse who's monitoring patients at home. She or he has no choice but to say, I can only take 20 people because I need to call them every other day and speak to them for an hour. And that's 10 hours plus 10 hours is 20 hours every other day. Now, all of a sudden, you have a generative AI tool monitoring the 20 of them. And she says, no, I really need to speak to 4 of them, both today and tomorrow, by the way. And there's a lot of them that do not. So now I can take care of 40 people. Now you've started to make it cost effective. That's the opportunity. So I think the fragmented single practitioner no longer works with chronic disease and the complex diseases that people have and the extended life longevity. But I also believe that the independence of that group, they have to select a leader. They have to be willing to all agree on common protocols. But again, we're science. Why should every one of us figure out how to manage a medical condition differently? Let's sit together, look at the literature, and decide what is best. And I'd say not always, maybe 80% of the time, we can come up with an agreement that we all can follow. So it won't matter if I'm on call tonight or you're on call tonight. We can provide great care to our combined set of patients.
Dr. Pearl, you are an American treasure. I follow religiously, I follow your postings. You're one of the best way. I've been in healthcare for a long time. I suggesting even Swapna to, just follow up your articles they are really tremendous wealth of information. You not only, the true leader's quality is that not only point out the problems, you give a pragmatic solutions. That is always, I admire that, you always come back with a solution. You're a true American treasure. I hope you will be policy making somewhere, fourth Korea, we want to have you, so not a third one, fourth one you need, because longevity, we are going to live longer. So thank you, sir. It is a truly.
Can I add 2 things? One is I know that some of your viewers are in India right now, 7:30 in the morning or whatever time it is in the morning rather than now, or 8:30 by now. I think places like India could lead the process because there you have the same challenges that you mentioned in rural Georgia. You have a lot more people than the ability of the clinicians to provide the care. And how can we use this technology? I think if the people in India can help to drive it and figure it out, we in the United States can learn a tremendous amount from them. The other thing is I encourage people to go to my website, robertpearlmd.com. If you have thoughts, if you have disagreements, let me know. I'm always wanting to learn, and I learn the most from people and their responses to me and thoughts about the things that I might say. Thank you so much for hosting the podcast and for inviting me to be your guest today.
Thank you, sir. It is truly an honor and privilege to have you. Thank you, sir. Good night, all of you. There's coming back tomorrow, mental health. Tomorrow, I'm doing an episode on mental health with Christina Spatora from Bronx, New York. She is joining with us. Thank you all. Good night.
Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.